Hello, everybody. This is a quick podcast and information regarding spine surgery and trends in the spine surgery. Hello, everybody. What we need to know is that the spine surgery is one of the most performed kind of surgeries in the United States and will be the most performed surgery as well globally. By the time you're 70 years old, there's only 2% chance you don't have a spine problem. Obviously, not all of these spine situations, spine problems need a surgery, and that's a good thing, but many of them do. As a matter of fact, 1.62 million spinal fusions are performed in the United States in 2022, and that is increasing because population age is increasing, and that spine problem is becoming a very prevalent disease, as well as spine now is globally one reason for disability. All of that together, if there is a common problem, there are lots of new trends, there are lots of technologies to overcome the shortcoming of current industry. And the shortcoming of current industry is that spine is still performed about 80% old-fashioned way, in a very invasive way, with lots of the damage to surrounding tissue when we are performing spine surgeries, especially the fusions. And I'm asked about what are the trends and what's my opinion on that. Let's start with some major trends. Number one, robotic and navigation. Certainly they have their place, and I have been in many conferences when they talk exclusively about them. And as well, I have a PhD in computer science. I used to be inherently involved in building those machines and those navigation machines that help the surgeon in the brain to perform those surgeries. Certainly those machines in the brain, because the skull is not movable, very useful, has been useful for 40 years. Now, in the spine, which is segmental, those machines have been very difficult to use. Now, technology is getting mature, but after being involved in that very inherently and very deeply, I still believe that a surgeon who train and practice spine surgery is still more accurate than those machines. And those machines add tremendously to time of the surgery, which has huge impact on actually overall performance in the OR and patient's outcome. Like risk of infection is about significantly higher with longer surgeries, and those machines can add significantly to time of the surgery. As a matter of fact, in the time those machines are brought in and taken out of surgery, I'm usually done with my surgeries, and most of the surgeons I know are very efficient, and as well, in their hand, those machines do not add any regular surgeries. One of the danger here is that we are not giving it as a tool to a surgeon, but we are trying to establish a situation that surgeon doesn't have to have the skills and compensate for the skill with those machines. That can be extremely dangerous. The robots, at least at this point, I believe is nothing but a gimmick. They are not ready or truly helping the surgeon. Navigation is, but in special situation, as a tool to the surgeon, not as a replacement for surgeon's skill. Now, endoscopy. Endoscopy has been invented for coming from outside of the spine, very obliquely from lateral through Cambine triangle. And Dr. Cambine actually used that 40 years ago. We neglected it in the United States. It went to Asia and came back, made a comeback in pieces. And that is actually a technique I use, a transcambine approach, to do my fusions. I use X-rays, not endoscopy, and certainly it is a trend. And for lateral approaches and for thoracic approaches, for extraforaminal approaches, meaning coming truly obliquely from outside, is a huge advantage. But coming from for most of the regular surgery, for 90% of the surgeries, the method we neurosurgeon use a tube, and that tube is about 2/3 of an inch or 18 millimeter. That have been established is very fast, very efficient, and actually faster in comparison to endoscope. I use my two hands. I have 3D vision on the bottom of the tube, because the microscope brings the axis of my eyes closer. I can look 3D. So in comparison, using endoscope is like fighting with one arm and one eye, one arm bandit, the so-called one arm bandit, has not been really helpful to add any additional value. It's a huge marketing practically name, but not really truly useful for people who are very efficient, doing it in the tubular way. And I do argument that if you do a tubular microdiscectomy or decompression, by using two hands and have a 3D vision, you can actually perform better. Now, for extraforaminal approaches, a macroscope cannot look that deep, so that could be an advantage, actually. Now, there are some other additional technologies like augmented reality, which is an offshoot of endoscopy and so on. And those approaches can be as well helpful in the future, but at this point is just a gimmick or very, very rudimentary. AI, at this point, I think AI is most going to help us for preparing the patient for the surgery, getting proper information, but less and actually helping us in the surgery itself. Then there are some question about the regenerative medicine. At least at this point in 2023, all those stem cell or plasma activated material that are injected back to the body so far has not been shown to have any additional benefit. As a matter of fact, some of them have been shown to be not beneficial, not only not beneficial, but actually harmful. For that reason, in the United States, only few of them are approved. Now, obviously, there are lots of non-fusion alternative, and including artificial disc, that so far, based on industry research and so on, they have been shown to be as good, but not better than fusion in about 7 to 10 years. And even we thought if we use what we call arthroplasty or artificial disc in the neck, the rate of other level going bad would be lower. Study shows the same. It's really not better, but as well, it hasn't been shown to be worse in the neck. In the lumbar spine, I just was in Germany. People who have invented artificial disc in the lower back have quit using it because it seems to be result actually worse than the fusion. And it makes sense. This mechanical device have a life expectancy, and contrary to fusion, no mechanical device will last forever. Trying to revise any of those machines or joints in the long run is can be extremely risky in the lumbar spine. I think it is going to have a future, but I don't believe our technology has been really ready for that. Now, let's talk about few good trends. Minimal invasive is becoming more and more advanced, and more people are doing minimal invasive surgeries, and more surgeons are getting trained. Now, at the end of the day, it's about the experience of your surgeon. If your surgeon needs to do a minimal invasive surgery 4, 5, 6 hours, there's nothing minimal invasive about it. It's about efficiency, lower time spent in the OR, lower blood loss, lower risk of infection, and so on. And I think this is about learning curve of the proper and properly learned procedure that makes a minimal invasive. I'm sure that every surgeon calls what specifically they do minimal invasive, and so because there's not an exact definition of that, more or less make your own research. These informations are available for everybody to look them up. Now, on the other side, there are some additional technologies that have been brought to the market for minimal invasive treatment of the spine, like so-called spinal process devices that there's a piece of metal that we put in the back of the bone to lift them up. This machine, these interspinal process devices like CoreFlex and so on, has been in market for a long time. Similar devices have been in the market for a long time. Most of surgeons quit using them about 10, 15 years ago because they have a temporary effect, but your bone remodels around them and the effect goes away. More or less, most of surgeons quit using them, but now as pain specialists see that as an opportunity to offer to the patient. I have revised tremendous number of them and taken them out. So I don't believe they're going to have any role in the future care. But does going to have a future practically explosion in number of procedures performed is sacroiliac joint. For a long time, we have neglected the sacroiliac joint, and many times we tried to go and do surgery traditional way, and the surgery was more damaging than helpful. In the last 15, 20 years, we do this procedure minimally invasively without damaging too much. And there are two ways of doing that. Devices that go inside of the joint and devices that cross the joint. For all practical purpose, I don't believe in the devices that go inside of the joint, literally. If you are trying to put the joint together, by the way, sacroiliac joint have only motion when the woman is giving birth. It has no other function. And especially in women, more than men, actually causing problem. To immobilize it is a very good option to relieve the pain. So devices that go inside of the joint, I don't believe they have really the opportunity to relieve the symptoms in the long run. They actually distract. But those are mostly the devices are promoted to the pain specialists and interventionalists. I believe more in the devices that cross the joint, like a screw. And those, obviously, that is how I would connect two wood together, putting screws across rather than put something between them. Putting one screw across, they can still rotate around it. So we have to do 2 or 3 screws across, so to immobilize them properly. And doing that, it has become really efficient way of treating that. 2 or 3 screws are needed. I think that is going to be the most exciting new development in the musculoskeletal and spine treatment, because there are many people who are neglected. People go and get the spine pathology looked at, and they're told there's no problem, there's no reason for your pain, and they're sent away. In truth, their problem is not the spine, but where the spine and the pelvis joining, which is a sacroiliac joint. So if you have any question, we have a lot of educational material. Please go to our podcast, our webpage, our YouTube channel. There are a tremendous amount of other